Hello everybody. I am Mohit. I am studying in second year MBBS at KRIMS Carver. Today I am here to present the topic glioblastoma. We will study the topic glioblastoma under the headings etiology, its pathogenesis, its morphological hallmarks and clinical presentation. Firstly, let's see its classification and pathogenesis. The molecular drivers, genetic updates, and oncogenic cellular pathways which are occurring in glioblastoma. Classification of glioblastoma. Glioblastoma is broadly classified into IDH wild type and IDH mutant astrocytoma. IDH means isocitrate dehydrogenase. IDH wild type glioblastoma is also called primary glioblastoma. Next, IDH mutant astrocytoma is also called secondary glioblastoma. Primary glioblastoma comprises 90% of the cases of glioblastoma, and secondary glioblastoma comprises 10% of the total cases of glioblastoma. Primary glioblastoma. It typically arises de novo in adults where median age is between 60 years, characterized by extreme virulence presenting rapidly without a recognized lower grade precursor lesion. Molecular hallmarks in primary glioblastoma are EGFR gene amplification, where EGFR means epidermal growth factor receptor gene amplification, and PTEN mutation, that is phosphatase and tensine homolog gene mutation, CDKN2A bar B deletion, and TERT promoter mutation, that is telomerase reverse transcriptase promoter mutation. Next, secondary glioblastoma. It progresses gradually from a pre existing WHO grade 2 or 3 diffuse astrocytoma, commonly diagnosed in younger cohorts, median age group between 45 years. The molecular hallmarks in secondary glioblastoma is IDH1 or IDH2 mutations, TP53 inactivating mutations, and ATRX loss. Now let's see some of the core pathogenic pathways where the DNA mechanisms or pathways which are altered in glioblastoma. These are the three pathogenic pathways which are primarily altered in glioblastoma. First, RTK, RAS, P13K pathway alteration. Next, P53 pathway alteration and RB pathway alteration. First, let's see about RTK, RAS, and P13K changes. Overactive growth signaling. There is a overactive growth signaling that had happened in this pathway, which is driven by EGFR amplification or mutation and loss of PTEN, a key regulator that normally acts as an off switch for cell growth. P53 pathway. Here there is defective DNA repair, inactivation of P53 tumor suppressor via point mutations or genomic deletions, allowing highly damaged genomic unstable cells to escape physiological cell cycle arrest. RB pathway alteration. Here there is unchecked replication that had happened where inactivation of retinoblastoma tumor suppressor, commonly via homozygous deletion of CDKN2A bar B, forcing the cell into rapid endless G1 or S phases. Next, let's move on to the main topic of glioblastoma, that is gross and microscopic feature. Here let's see about classic gross anatomy and key histological diagnostic hallmarks of glioblastoma. Firstly, let's see gross morphology. The variegated appearance is the well-known hallmark of glioblastoma. Glioblastoma classically presents as a poorly demarcated, infiltrating intraparenchymal brain tumor with distinct regions. There are three distinct regions: yellowish zones, reddish brown areas, gray white outer ring. Yellowish zones In yellowish zones, there is ischemic coagulation necrosis that had happened. In reddish brown areas, there are recent and old hemorrhages that are easily can be identified. Gray white outer ring, there is fast growing viable tumor rim. In the picture given, you can easily see and identify the tumor mass in the brain. The tumor mass commonly crosses the corpus callosum into the opposite hemisphere, forming a bilateral butterfly glioma pattern. Let's see its microscopic features. Here there is cellular pleomorphism and anaplasia present in the glioblastoma. The classic histopathological profile shows extreme architectural disorder, extreme atypia, nuclear hyperchromasia, and high mitotic activity. There is variable cell size, bizarre multinucleated tumor gained cells, and highly dysplastic astrocytic processes. In nuclear hyperchromasia, there are dark, enlarged, irregular nuclei displaying heavily clumped chromatin. And there is high mitotic activity where numerous and abnormal mitotic structures representing accelerated karyokinesis can be noticed. You can notice the three areas in the picture where there is large hyperchromatic cells and there is necrotic focus and mitotic cell seeing in the picture. Now let's focus on the main microscopic pathognomic hallmarks in glioblastoma. There is pseudopalisading necrosis, which means serpiginous bands of tissue necrosis lined by closely packed radially oriented tumor cells are present. The cells stack along the edges as they actively migrate away from severe hypoxia. Here you can see the area of pseudopalisading necrosis where there are serpiginous bands of tissues necrosis lined by closely packed radially oriented tumor cells. Microvascular proliferation. Vascular endothelial growth factor secretion induces dense redundant loops of newly sprouted endothelial and smooth muscle cells, creating complex vascular coils mimicking renal glomerular tufts. The next feature in the microscopic hallmarks is thrombosis and vascular occlusion. The newly formed blood vessels are structural anomalies prone to microthrombi. This occlusion leads to local tissue death, expanding the necrotic zones. So, according to WHO, by confirming these three microscopic hallmarks, we can diagnose the glioblastoma. Now, next move on to diagnostic and prognostic biomarkers. There are four classifications of glioblastoma as pathological markers that are glial fibrillary acidic protein, IDH1 and IDH2 status, MGMT promoter methylation, Ki67 proliferation index. In glial fibrillary acidic protein, it confirms the glial origin of highly undifferentiated pleomorphic tumor cells, and its status in classic primary glioblastoma is positive. In IDH1 or IDH2 status, it is crucial for ruling out secondary progression. Wild type status carries a worse prognosis. Its status in classic primary glioblastoma is wild type, which comprises for about 90% of the cases of glioblastoma. Next, MGMT promoter methylation marker. Silencing of DNA repair gene predicts favorable tumor sensitivity to alkylating chemotherapy, and its status in classic primary glioblastoma is variable. Next, K967 proliferation index. Its significance is that immunohistochemical assessment indicating high cellular turnover and growth speed, and its status in classic primary glioblastoma is highly elevated. Next, let's see the clinical presentation of glioblastoma. Clinical presentation is noted as mass effect, seizures, and focal deficits. Due to rapid mass expansion and severe peritumoral vasogenic edema, patients present with headache, which usually worsens in the morning, nausea, and focal papil edema. Compression and localized ischemic irritation of cortical gray matter by underlying tumor will trigger new onset generalized or partial seizure activity. Localization dependent impairments such as progressive hemiparesis, localized sensory loss, sensory aphasia, or cognitive decline occur over weeks. Next, let's see about its prognosis and survival expectations. 12 to 15 months of median survival. What it means? The patients with the glioblastoma usually survive for 12 to 15 months. According to standard step protocol, the clinically accepted gold standard for managing IDH wild type glioblastoma is maximal safe resection and temozolomide chemotherapeutic agent. Maximal safe resection. Initial debulking surgery to remove the main macroscopically visible tumor mass is done. Next, use of temozolomide, the oral alkylating chemotherapy administered concurrently with radiation therapy and thereafter as a adjuvant therapy. Deep cellular tissue invasion guarantees high disease recurrence rates in post therapy cases. This is about glioblastoma. Now, once let's revise about microscopic and gross features of glioblastoma, which may be asked in the exam. This is the gross feature of glioblastoma. The variegated appearance. Glioblastoma classically presents as a poorly demarcated infiltrating intraparenchymal brain tumor with distinct regions of yellowish zones, reddish brown areas where there is recent and old hemorrhages, and grey white outer ring where there is fast growing viable tumor rim. In microscopic features, there is extreme atypia, nuclear hyperchromasia, and high mitotic activity. Three pathognomic hallmarks of microscopic feature is pseudopalisading necrosis, which can be seen in this picture, and microvascular proliferation. This happened due to PEGF secretion, which induces dense redundant loops of newly sprouted endothelial and smooth muscle cells, and thrombosis and vascular occlusion, where the newly formed blood vessels are structural anomalies prone to microthrombi. This occlusion leads to local tissue death, expanding necrotic zones. There is variable cell size, bizarre multinucleated tumor gain cells, and highly dysplastic astrocytic processes, which can be noticed in the picture. Dark, enlarged, irregular nuclei displaying heavily clumped chromatin. This can be noticed in this zone. And there is high mitotic activity. There are numerous and abnormal mitotic structure represented in the accelerated karyokinesis. Here is the zone of mitotic cell, where you can notice the highly active cell which is dividing. These are the main microscopic and gross features of glioblastoma. Thank you.